morning. We're going to start the day with the endoscopic assisted approach to the round window during cochlear implantation. Optimal electrode placement inside the cochlea is needed to maximize the success of cochlear implantation. The standard procedure described by House comprises mastoidectomy, posterior tympanotomy, and approaching the cochlea guided by the round window. The posterior tympanotomy, despite being an easy procedure to perform, however, it carries the risk of injuring the facial nerve, especially in anteriorly placed nerve, or the chorda tympani in cases with narrow posterior tympanotomy. That's why Krukenberg et al. Approached the basal turn of the cochlea through a suprameatal approach. The improved knowledge of endoscopic middle ear anatomy, particularly that of the round window, increases the opportunity for endoscopic cochlear implantation, avoiding mastoidectomy and posterior tympanotomy. This depends mainly on the direct visualization of the round window, which permits insertion of the electrode array through the round window membrane directly to the cochlea in its basal turn, and especially the scala tympani of the cochlea. For a long time, cochlear implantation emphasizes on implanting safe and reliable electrode array into the bony cochlear channel. The round window, despite providing a reliable landmark, however, the relatively stiff multi-channel electrode design and the hook region of the cochlea may cause difficult insertion and injury to the osseous spiral lamella, which transmit the peripheral auditory nerve fibers, with subsequent adversing the post-operative audiological performance of the patients. This is the hook region of the cochlea, and this is the round window after opening. This is the scala tympani of the basal turn of the cochlea. We can see the osseous spiral lamina with the small fine blood vessels over it. But with the advances of manufacturing of more flexible and softer electrode arrays, the round window insertion become less traumatic to the basal turn of the cochlea if compared with the classical cochleostomy approach. In this study, we aim at evaluation of the detailed steps of the endoscopic assisted epitympanic approach to the round window as a safe, less traumatic, and reliable approach to the round window. 30 cases was done in this study. 20 of them cochlear implantation was done through the endoscopic assisted epitympanic cochlear implantation using the 0 and 30 degree autoendoscope, and only in 10 of cases the classical Fisher recess approach were used as a control. The endoscopic assisted approach comprises both the use of the microscope and the endoscope. The microscope for the limited mastoidectomy, creation of an epitympanic tunnel, middle ear approach, the tympanomeatal flap elevation, and the bed, drilling of the bed housing the receiver stimulator complex, while the endoscope connection from the epitympanic channel to the middle ear, preparing the round window region, guiding the array tip from the mastoid through the tunnel to the middle ear, and lastly the endoscopic insertion of the array to the basal turn of the cochlea. This is the first step, which is the middle ear exposure. Here we can see elevation of the posterior canal skin flap of the external auditory canal till we reach the tympanic annulus without incising it. This ends by visualization of the retrotympanum. The retrotympanum, which contains the round window region and the incudostapedial joint. This is the end of this step. Here we can see the retrotympanum and the round window, which is not that evident by the microscope. While with the use of the endoscope, here we can see the endoscopic evaluation of this region. We use the 0 endoscope for magnification. Here is the incus, the long process of incus, incudostapedial joint, stapes, and stapedius tendon, and this is the round window region. This is the anterior limb, this is the posterior limb, and this is the niche. So with the use of the endoscope, there is no limit for the boundaries of vision. However, the anterior limitation, the tympanic membrane, tympanomeatal flap complex, and the malleus is sufficient, while posterior, the incudostapedial joint and the stapedius is sufficient. This is the round window pre-chamber or the round window region, which is the crucial point in cases with cochlear implantation. It's very clear the difference between the use of the microscope and the endoscope. You will never get this in a microscopic view. This is the round window pre-chamber. This is what we term the tegmen, and this is the anterior pillar, and this is the posterior pillar. The round window is present in the depth, or the round window membrane is present in the depth. This point is of very importance as it is the term the infracochlear air cell tract. This may be a misleading for many surgeons as they may do insertion through this, so will end up in an electrode array not inside the cochlea but in elsewhere, maybe Eustachian tube, carotid, or whatever. The second step is the partial mastoidectomy with the use of the microscope. We don't do large mastoidectomies because we are not in need for this. We just do the mastoid as a vehicle or a track to allow us to pass the electrode from the mastoid to the middle ear. Removal of the old mastoid ear cells will leave a smooth cavity and encourage extrusion of the implant array. Also, there is no need for removal of all mastoid cavities because it is not a chronic suppurative otitis media. You are dealing with a normal middle ear. Also, leaving overhang will retain the excess electrode and the ground electrode, if any, avoiding extrusion. Then we do drilling of the epitympanic tunnel. As we'll see, the boundaries of this tunnel is lateral surface of the short process of incus and the medial surface of the posterior canal wall in the region of the attic or the mesotympanum. Here we can see we continue drilling using 1 or 1.5 millimeter diamond drill or cutting drill. It doesn't matter because this is safe area. We continue drilling till we do a tunnel sufficient enough to pass the electrode array from the mastoid to the middle ear. Here we can see the tip of the needle, Rosen needle, passing from the mastoid. We can see it inside the middle ear. So it will be sufficient to pass the electrode itself. Then we verify the patency of the epitympanic tunnel using a 30-degree endoscope. Here we are passing with the endoscope. This is the tunnel from the mastoid. It's of no value now. Here we are going inside the mastoid cavity. This is the short processive incus, the lateral semicircular canal, and then we are going to see the tunnel itself. This is the tunnel, which will be the track for passing of the electrode array from the mastoid to the middle ear. Then we get to the most important point, which is the round window region preparation. We start drilling using a 0.5 millimeter diamond drill. We start drilling along the tegmen of the round window from posterior to anterior. We continue drilling till the round window membrane starts to appear. This is the round window membrane. We incise it carefully using a second knife or even the tip of the suction tip. Here it starts to open. We can continue removing the membrane using a second knife or even the suction tip. So here we are sure inside the scala tympani of the basal turn of the cochlea. We can identify the osseous spiral lamella. Also, we can identify the very fine blood vessels overlying it. And this is the region of the hook of the cochlea. It's impossible to identify these structures using the ordinary microscope or even the 3D microscope. Here, the blood vessels lining the basilar membrane or the osseous spiral lamella separating the scala tympani from the scala media is very evident. This is another round window preparation. This was a very tricky case, as without the use of the microscope, you may pack the electrode in front of the round window because the round window pre-chamber is deep. You can pack it inside this chamber, assuming that you are inside the cochlea, which is not true. Here we can see the round window is facing postero-inferior, the round window membrane. Here we continue drilling from posterior to anterior along the tegmen of the middle of the round window. This is the membrane start to appear. This is an abnormal location of the round window. It faces postero-inferior. We start removing the remaining part of the membrane with a hook, micro hook, till the scala tympani opens. The last step was the insertion of the electrode array into the cochlea. It's a four-handed step. The assistant supports the electrode from behind while the main surgeon continue insertion from inside using the endoscope. Here is the array passing smoothly through the scala tympani of the basal turn of the cochlea. We continue thrusting the electrode inside the cochlea till we reach to a stop, which is called the stopper or the knob of the electrode array. This is the incudostapedial joint and the incus lung process. We can notice that we do a very shallow tunnel over the promontory for the electrode to pass over the promontory to avoid the kinking of the electrode, because this is not the usual track we use in cochlear implantation using the posterior tympanotomy approach. I wish the videos are clear. The problem is, or the argument against this technique is the electrode direction. Here we can see the electrode direction in the suprameatal approach, while this is the direction in the classical approach. In the classical approach, it is in line with the site of entry of the electrode inside the cochlea, while here there is an angulation. However, we overcome this angulation by the four-handed technique and doing a shallow groove over the promontory as it the electrode crosses towards the cochlea. Here we can see this is the electrode passing over the promontory. We do a shallow groove, and the four-handed step, the assistant support from behind, as you see, while the main surgeon do insertion from inside the middle ear using the endoscope. We assess the results radiologically by the depth of insertion and the scalar location. The depth of insertion, we use both the linear depth of insertion and the angular depth of insertion. The linear depth means the length of the electrode inside the cochlea in millimeter, while the angular depth of insertion is the angle or the degree of rotation the electrode do in relation or in reference to a specific point. Usually the round window is taken as this reference. This is a linear insertion depth from here to here in millimeter. Usually it's 12 to 15 millimeter, according to the patency of the cochlea, whether partially ossified or narrow or whatever. And this is the angular depth, the angulation, the tip of the electrode form in relation to a specific point, usually the site of entry in the cochlea, whether the round window or the cochleostomy. We find that there is no significant difference between both approaches regarding linear and angular depth of insertion. While in scalar location, a significant difference was found in cases with round window membrane. More than 90% of the electrodes were 100% inside the cochlea, in the scala tympani of the cochlea. While in the cochleostomy, it is only 70%. The only one case in the round window approach was an ossified cochlea. We were not able to put the insertion or to do insertion in the scala tympani, and we used the scala vestibuli as an alternative. This is an oblique sagittal reconstruction, CT. We can see the scala tympani containing the electrode, while the scala vestibuli is totally empty from the electrode. This is a temporal bone model. I did it with my professor Gibson in Australia. This is ordinary cochleostomy insertion, and this is round window insertion. This bone is called crista fenestrum. The point of first contact of the electrode to the basilar membrane in the cochleostomy group is 5 millimeter far anterior. So the contact length of the electrode to the modulus is 5 millimeter less in cases with cochleostomy if compared to the round window. The advantages of round window membrane approach is the round window insertion provides a safe, reliable technique to access the basal turn of the cochlea with minimal intracochlear and extracochlear trauma. The final intracochlear electrode position is different between the round window insertion and the ordinary cochleostomy. The round window is more in favor with the perimodular location of the electrode within the cochlea. At the round window insertion, the proximal part of the electrode is held closer to the modulus with the crista fenestrum, which is normally taken in cases with cochleostomy approach. Round window insertion provides an almost sure approach to ensure the implant array in the scala tympani of the basal turn of the cochlea. Also, the round window is the only stable landmark to avoid insertion in wrong places. Mostly the inferiorly, the infracochlear air cell tract or the hypotympanum, superiorly to the vestibule, anteriorly to the Eustachian tube, or posterior to the facial recess and the sinus tympani. The problem is the different anatomical variations of the round window, which comprises a problem to the surgeon. However, with the use of the endoscope, you can identify the round window and its anomalies. As we see before, a posterior-inferiorly facing round window, anteriorly facing round window, an infracochlear air cell tract which may be misdiagnosed or as a round window membrane. This is the tegmen of the round window. This is the infracochlear air cell tract. If you try to introduce the electrode through it, it will pass easily without any resistance, may ends up in a cochlear implant array inside the Eustachian tube, or more catastrophic end towards the carotid canal. As we mentioned before, the angulation, which is the only problem we faced in this technique, have been overcome. We concluded that endoscopic assisted cochlear implantation is a safe and reliable technique with a lower rate of complication. The magnificent power of optics of the endoscope to see around the corners in the retrotympanum and the epitympanic region could be a useful, safe alternative for different non-endoscopic approaches in cochlear implantation for optimal localization of the round window region and precise and certain location of insertion in the scala tympani of the basal turn of the cochlea. In our cases, we didn't face any reported complication as residual tympanic membrane perforation, extrusion of the implant, or difficulties because of the angulation of insertion. Thank you.
Any questions?
What do you mean by the four hands?
Four hands, if you are using the microscope alone, if you are doing a surgery for the ear using the microscope, what's the role of your assistant? Nothing. If you use the endoscope,
you have one hand.
You use one hand, and the other hand you manipulate, while the assistant can see with another endoscope from the other side, from superior. Both two surgeons can work in one case. You understand me?
Does he have a role in the insertion of the
No, he just supports the electrode from the mastoid side, and you do insertion from the middle ear side.
Okay. Regarding the creations of the tunnel.
Tunnel, yes.
Yeah, we are passing behind the annulus.
Behind the annulus, yes. You
just
pass
in the middle
from the attic.
Yeah.
In a tunnel you did in the posterior canal wall.
Yeah.
Then you pass over the promontory. Passing over the promontory, the electrode